Dear colleagues, first, I would like to sincerely thank the organizers for the kind invitation to speak at this esteemed Congress. It's truly an honor to be here among such distinguished colleagues and experts, and I'm grateful for the opportunity to share our work. I don't have any financial interest in this presentation. The prevalence of dry eye increases with each passing decade of life starting at age 40. Prevalence of dry eye symptoms in women is higher than in men. Although literature reviews have not just suggested a positive correlation between presbyopia and dry eye disease, the aging population primarily constitutes the majority of patients who report symptoms consistent with those of dry eye. It is estimated that 2 billion of the nearly 7 billion people on the planet are presbyopic. There are many risk factors for DED. They are classified as consistent, probable, and inconclusive. Also, risk factors could be non-modifiable and modifiable. Let's speak about role of hormones. Sex hormones are constantly changing in the presbyopic adult. Both estrogens and androgens influence the synthesis and components of the TF film, including the lipid, aqueous, and mucin layers. The meibomian glands have androgen binding receptors that play a part in the synthesis and secretion of lipids. Estrogen actually causes a decrease in lipid production, and increased levels of estradiol are believed to be a risk factor for dry eye. However, the relationship between sex hormones levels and dry eye treatments remain controversial. The effects of estrogen and androgen therapy to treat dry eye are not well understood. There is another risk factor for DED in presbyopic patients that is discussed in papers, and it is time working in media. Presbyopic adults spend a majority of their working hours viewing digital media, and they should undergo a thorough assessment of their ocular alignment and refractive demands in addition to standard dry eye workup. According to the Nielsen's Total Audience Report, adults between ages 50 and 64 years spend an average of 13 hours, 50 minutes connected to media, which is twice the amount spent by adults between age 35 and 49. Cataract surgery is among the most frequently performed procedures worldwide. Although it is cost-effective with a significant socio-economic impact, increasing patients' economic productivity, social autonomy, and quality of life, it is not a risk-free procedure, and undesired effects or iatrogenic conditions may occur even after an uneventful surgery. The most frequent postoperative complaints are related to ocular surface disturbances characterized by a wide range of symptoms, including a foreign body sensation, photophobia, burning, fluctuation vision, and epiphora. It makes patients unhappy. And this finding is not surprising, since most surgical procedures are performed on the older population that is characterized by a more frequent presence of ocular surface impairment. So, when we are speaking about the prevalence of DED after cataract surgery, it is unclear. And according to some studies, DED is met in 9% of patients 4 weeks after surgery, and in 31% at the 4 weeks after surgery. Dry eye disease after cataract surgery is associated with various risk factors while causing a wide range of heterogeneous symptoms, including decreased quality of vision. The pathogenesis of DED after cataract surgery remains unclear, resulting in a lack of evidence-based established treatment. Moreover, there have been no systemic or large-scale studies on DED following cataract surgery in individuals without pre-existing DED to comprehensively elucidate its risk factors, duration, and treatment. Besides cataract surgery, refractive glaucoma and eyelid surgeries can also determine newly developed DED or worsen pre-existing DED according to different mechanisms of action. Overall, more than 30% of patients without pre-existing DED develop DED after cataract surgery. The term Stod's surgical temporary ocular discomfort syndrome had therefore been coined to describe the transitory perturbation of the ocular surface induced by surgery or laser surgery. However, in some cases, the insults result in a chronic ocular surface disease named surgical chronic ocular discomfort syndrome. Accordingly, preoperative evaluation in the FACO study, even though upwards of 60% of routine patients screened for cataract surgery were asymptomatic, and 50% of them presented central corneal fluorescein staining. In other study, it was mentioned that the prevalence of ocular surface disease in patients presenting for cataract surgery was higher than 80%, and more than 50% of asymptomatic patients had abnormal tear osmolarity. A recent annual ACRS clinical survey reported that despite more than 80% of respondents feeling that DED affected patient satisfaction after cataract surgery, only 10% of them were using diagnostic testing in their routine preoperative assessment. So, careful history taking and maintaining a high index of suspicious for DED is important, considering it is frequently seen in patients presenting with cataract. An objective way of assessing the symptoms would be used to use questionnaires such as the Ocular Surface Disease Index and others, and a recently developed index called the Ocular Surface Frailty Index, or OSFI, has introduced the concept of ocular surface frailty, making it susceptible to develop in DED. The main steps in screening are presented on this slide. Under the slit lamp biomicroscopy, a clinician should evaluate anatomical structures of the lid, including the alteration of lid margins and eyelashes. Meibomian gland dysfunction refers to the condition where the glands are not secreting enough oil, or when the oil they secrete is of poor quality. Often the oil gland openings get plugged up so that less of oil comes out of the glands. The oil that does make it out of the glands can be granular, crusty, or otherwise unhealthy and can cause inflammation. The alterations of the lid margins include hyperemia, telangiectasia, thickenings, keratinization, ulceration, tear debris, and many other abnormalities. And careful evaluation of meibomian glands is important, since its dysfunction is the most frequent cause of evaporative DED and is often symptomatic. Evaluate if the meibomian gland are plugged or obstructed. It's very important. Lid parallel conjunctival folds are well accepted clinical sign in dry eye diagnosis. Also, staining with fluorescein sodium is one of the most common methods for studying DED and examining the surface of dry eye. Staining is also a marker of inflammation and severity of dry eye disease. And commercially available non-invasive diagnostic tools for DED opens a new perspective in the screening of patients undergoing ocular surgery. These devices offer the advantage of obtaining automated results, avoiding subjective bias. Moreover, since these examinations are non-invasive, they do not alter the results of subsequent examinations, representing useful tools for screening healthy subjects from patients affected by DED or those at risk for DED. Meibography is an imaging study developed 35 years ago and exclusively for the purpose of observing the morphology of meibomian glands also is possible to perform with these tools. The tear film acts as the first refracting medium, with the magnitude of change in refraction at the AIT film interface being the largest compared to any other interface in the optical system. Alterations in tear film physiology therefore impact the overall quality of vision, with an increase in higher order aberrations and irregular astigmatism. It is not uncommon to have an overestimation of astigmatism in eyes with DED owing to the fluctuations of keratometry values caused by alteration in the tear film osmolarity despite having an otherwise clear cornea. It is advisable to correlate astigmatism with the refractive acceptance of the patient also. In case of discrepancies, biometry should be repeated after the ocular surface is treated. Instruments like keratometers, topographers, and wavefront analyzers relied on the precorneal tear film for acquisition of the biometry parameters. Indices such as surface regular index and surface asymmetry index are incorporated into the topographers and help understand the status of the ocular surface. So preoperative optimization of the surface not only helps in the clinical improvement of DED, but also improves the accuracy of the optimal measurements. Treatment strategy in DED is step up. First-line treatment usually focuses on patient education, risk factors, and achieving relief of DED symptoms. The usage of medications and technologies depend upon severity of disease. But also don't forget about eyelid hygiene in the management of MGD. We can use for this purpose different types of masks for warming and stimulation of meibomian glands. There are many new technologies like light energy from IPL that could warm the meibomian glands, and therapy facilitating expression of meibomium and stimulate meibomian glands as well. Many options are available for the treatment of MGD, but most insurance plans cover only pharmaceuticals. Low-level light therapy is a low-cost entry point of MGD management and is effective both as a standalone procedure and in combination with IPL therapy as well. So we can use, of course, new innovations for stimulation of tear film production, silicone punctal plaque in the severe cases. Intraoperative factors like toxicity from medications, surface drying, surgical incisions, surgical time, phototoxicity, they're important in the pathophysiology of cataract surgery-induced atherogenic DED. Excessive use of povidone iodine or topical anesthesia is known to cause epithelial toxicity. Coating the ocular surface with dispersive viscoelastic has been shown to reduce postoperative DED as compared to using a balanced salt solution. The size of the incision has an effect on the postoperative ocular surface status due to coronal nerve transaction. And additional measures can help reduce worsening of pre-existing DED. And when we're speaking about post-operative considerations, we should keep in mind preventing de novo DED. That includes screening, use of preservative-free lubricants, and other methods of treatment. And also, we should always keep in mind pre-existing DED without keratopathy and pre-existing DED with keratopathy that could include different ways of prevention severe damaging of ocular surface. Complications following cataract surgery in pre-existing dry eye disease include posterior capsular and discement membrane detachment, wound link and zonal dialysis, and commonly overall surgical complication rate is more than 6%. So as a summary, the insult caused by cataract surgery is known to cause DED de novo and worsen pre-existing ocular surface disease. The careful preoperative examination might help diagnose subtle signs of DED in asymptomatic patients. In patients known to have DED, biometry needs special considerations and IOL power calculation might be inaccurate. Despite an uneventful, careful planned surgery, DED symptoms are common. Preservative-free lubricants restricting the use of non-steroid medicine and use of topical and systemic immunosuppressants were indicated help to improve ocular surface health. So appropriate preoperative, intraoperative, and postoperative measures are taken timely to improve patient outcomes. Thank you for your attention.